Top Bed Talk.
So we have it's great to have Ramani Moonesinghe, who is Professor of Anaesthetics at UCL and the Chair of Health Services Research for the Royal College, and she's going to talk about SNAP-2.
Morning, everyone. So I'm here to present results of analysis looking at the accuracy of risk prediction tools in an international cohort of patients. So the SNAP-2 EPICCS study was created to look into some of the issues around the epidemiology of critical care after surgery. In the United Kingdom, we believe that we've got quite a significant problem with critical care capacity for patients having major surgery. So our recommendations from our national guidelines are that patients with a predicted mortality risk of greater than 5% at 30 days should go to critical care. But there's uncertainty in the guidelines about how we should estimate this, which sort of risk prediction tools we should use. And this is critical for us because we have this crisis in terms of hospital beds, particularly critical care beds. These are newspaper reports from the United Kingdom over the last few years, and we believe that this is not a UK problem, this is an international problem. Previous work from the same study, same cohort of patients, looked at risk factors for previous cancellation of surgery, and needing a post-operative critical care bed was a very, very significant risk factor. You were 3 times more likely to be cancelled on the day of your operation if you required a post-operative critical care bed for capacity reasons, as you would imagine. And organically, as a result of that, UK hospitals are building these enhanced care units. So a third of UK hospitals almost have one of these wards, which are little wards which do a little bit of critical care but are not quite a critical care unit. So they're trying to meet that need, but we don't quite know exactly how we should be estimating risk of patients, selecting patients for critical care, and indeed guiding the decision-making that we use throughout the perioperative pathway. So this study was aimed at doing these 3 things. To find out what we do in real life, so one of my research interests is improvement science or implementation science, and we hear a lot of really, really great science in meetings like this, but we don't really know what clinicians are doing in practice, so we wanted to find that out. We wanted to compare easy and affordable and non-proprietary risk tools against each other and against our own clinical judgment and see which is better. So we recruited patients in the United Kingdom, Australia and New Zealand for a week each in 2017. And our inclusion-exclusion criteria are worthy of a pause for a moment. We included all patients who were having inpatient surgery, so they required a hospital bed overnight after their operation, and required the services of an anaesthetist, not necessarily under general anaesthesia, but an anaesthetist was involved. But importantly, it was a non-consenting study. We got the required ethics and regulatory approvals in the UK and also in Australasia to be able to recruit every single patient that came through the doors during those weeks. And that's critically important when you look at the results of other studies where there are some real problems potentially with recruitment bias and sampling strategies in those studies. We wanted to compare 3 well-known previously validated risk prediction tools. The possum, which will be familiar to those of you who work particularly in the UK, the surgical risk scale, which is less familiar to most of us, but is a very simple score that's been previously validated in the British literature, and the surgical outcome risk tool, which is a relatively new kid on the block, but again, a very simple risk tool that can be used with an online calculator or an app. And then we asked the teams, so the perioperative teams before the patient had their operation, what they thought the estimated risk of death within 30 days were, and we asked them to categorise it into these broad categories here. So the results. So the first thing is that we recruited patients from 274 hospitals across the 3 countries. The majority of these were in the United Kingdom, but you can see that we got a very, very big sample of patients in those 3 weeks of study across the 3 nations, so nearly 27,000 patients. And we've had really, really high data quality, so only a very few number of patients were excluded for missing data. We then conducted various analyses looking at the accuracy of different risk prediction tools and comparing them against clinical judgment. The cohort characteristics, so 26,000 patients in the cohort overall. We also did some analyses on a high-risk subgroup, and we defined high risk using the same criteria as the METS study, which Daminda Wijetendra has presented yesterday. So these were patients who had previous cardiac disease, other comorbidities, were older, and so on. And about 13,000 patients went into that group. The distinction between males and females was different between the main group and the high-risk subgroup because we included obstetric patients in the study. And none of the obstetric patients fell into the high-risk group, as you would imagine. And the high-risk group were, as you would expect, also older. If you look at the distribution of ASA grades and the type of surgery that they were having, you also see some reassuring trends there in terms of the high-risk group having higher ASA scores and having more complex surgery. If you look at differences between the groups, again, in terms of the type of surgery they're having, that difference in terms of obstetric surgery there is evident. And in terms of past medical history, again, you can see that the people in the high-risk group had a much greater prevalence of various comorbidities. So the 30-day mortality in this cohort overall was 1.2%, and in the restricted group of high-risk patients, it was 2%. And previous work that's been conducted by Rupert Pearce and colleagues, and Tom Abbott in particular, looking at administrative data in the UK, demonstrate to us that our sample, as we hoped for, was representative of the real world. It was very, very similar mortality to what we know from administrative data. Excuse me. This is how clinicians estimate risk in real life. So if you look here, these are the various objective risk prediction tools. And in brackets, you've got the percentage of patients who had one of these tools used in their risk estimation. And it's really, really teeny tiny figures. Right down there, fourth from the bottom there, we've had a lot of discussion, rightly so, about cardiopulmonary exercise testing and its role in identifying patients who might benefit from prehabilitation over the last couple of days. But a very, very small fraction of this cohort had a CPAT test and had that used to guide their perioperative care. So the vast majority of patients, clinicians used their clinical judgment alongside the ASA score, and that was all. These numbers don't add up to 100% because people were able to score more than one thing that they used to help guide their risk. So this was from an editorial in Anesthesiology about 10 years ago, and the statement there was that we have this sort of industry around generating risk models, but actually the vast majority of them are actually not used, and that was certainly our finding in this cohort. We now look at the calibration of the various risk tools and the area under the curve. So the calibration, as you'll all recognise, is just how well the data fit the risk calculator that you've used. And what you want to see is the blue lines really as close as possible to that straight line going through the middle. And you can see that the P-possum is way, way off, surgical risk scale somewhat off, and the sort better, but still a little bit off. But if you look at the ROC curves, which is how well these tools perform in terms of discrimination, so how well they line up patients in order of risk in that cohort, the surgical outcome risk tool comes out best in terms of both calibration and discrimination. You look at clinician predictions, and the ROC curve is pretty convincing, but the calibration a bit less so. And so basically what we can draw from that is we line the patients up in order of risk pretty accurately, but we're really glass half empty when we come to actually predicting what their outcome is going to be. And here are the numbers from those. So if you look at the AUROC on the left-hand side, for clinical judgment versus the sort, versus a combined model which uses both clinical judgment and the sort, you find that actually the combination of clinical judgment and this objective risk tool is the best and is statistically significantly better. Now, this is a very, very big study, and so you might expect to see statistically significant results even if they were clinically not that important. So we did this other test, which is the Net Reclassification Improvement Index, which kind of gives you an idea of the clinical meaning of a difference between two different systems. And we found that using a combined model with the sort and clinical judgment improved the discrimination of the risk prediction tool. And the most important thing for us, which was surprising, is that the improvement that you got from this is it predominantly reclassified patients from being high risk into a low risk group correctly. So what that means is that those calibration curves that I showed you earlier, where it demonstrated that we're really natural pessimists, it is possible that if we use clinical judgment accompanied by the sort together, that we would actually correctly identify patients who don't meet that 5% threshold and therefore potentially might not benefit from critical care, which is relevant when you think about the service pressures that we all have. If you look at the high-risk subgroup of patients, you see similar results. The calibration and the discrimination of the tools was a bit worse, but not so much that you would particularly worry about it. So the key messages from this study are this. It doesn't really matter how many conferences we go to like this or how many risk prediction tools we generate. In real life, people are basically relying on their clinical judgment and continuing to do that. This is substantially the largest study which compares clinical judgment against objective assessment and to estimate the added value of using the both together. And we are pretty convinced that this is real data, a real-world cohort, and therefore generalisable to our day-to-day practice because we avoided those issues of recruitment bias. And this is an amazing, amazing study which Daminda discussed at length yesterday, and others have over the last year since it was published. And our results do conflict with the headline result of this in terms of clinician judgment actually not being that bad, we found, whereas it's quite clear in this study that clinician judgment should not be used to estimate functional capacity. But it's important to recognise that, first of all, the value of cardiopulmonary exercise testing wasn't the focus of our study. And the second thing is that they were looking at clinicians' ability to predict functional capacity or physical fitness. We were looking at clinicians' ability to predict which ones would die or not within 30 days. We were looking at different outcomes in that sense. And so the two studies are not directly comparable, but it does make me wonder whether the most important use of cardiopulmonary exercise testing in this setting would be for selecting patients who would benefit from interventions such as prehabilitation prior to their operation. So what do we need to do now? It was such a joy to find a possum in a dustbin, because I think that's what we can do with the P-possum score. We can focus future studies on recalibration and implementation of existing risk tools, and more importantly than that, start to think about how we use these tools to predict more important patient-centred and longer-term outcomes. But the key thing, and the thing that the MET study did, and the thing that other smaller studies, and indeed the ASOS study, which is happening in Africa at the moment, is doing, is looking at the impact of risk stratification on patient care, not just which tool is best. And we've really, really got to move into those studies now, where we randomise patients either at an individual patient level or a cluster level to an intervention based on their estimation of risk. We need to start thinking about whether the thresholds that we've got in the guidelines are, because they are pragmatic at the moment, but can we do better than pragmatism now? And think about what interventions we think might be useful in these patients, whether it's critical care or enhanced care or some other type of optimisation. And in order to make this valuable, we need to think about agile, efficient, generalisable trial designs. We need to think about recruiting huge numbers of patients very efficiently in the way that we were able to do through great collaboration, and using point-of-care randomisation if you've got electronic health records, citizen science approaches, and so on. So the final conclusions are that the surgical outcome risk tool is an easily applied, free, non-proprietary risk tool which requires regular recalibration but can be used to estimate risk in your patients, and when combined with clinical judgment, provides a highly accurate estimate of 30-day mortality in an inpatient population for surgery and a high-risk subgroup. My thanks to Danny Wong, who's pictured over there with his family. He's the trainee lead that led this study and did really all the hard work, and our 3,000 collaborators across the world. Thank you very much.
Nick Majerison here. Thanks for listening to Top Med Talk. Now, before we let you go, it's important that we remind you to subscribe to Top Med Talk. That way you'll never, ever miss another episode. Also, if we could encourage you to join us on social media, Twitter, Facebook, LinkedIn, YouTube, pretty much every single social media platform, we're there. Join us. And finally, check out topmedtalk.com. If you go to our website, you can subscribe to email updates. That way we can always tell you where we're going to be, what we're going to be doing, and how you can join us. topmedtalk.com, and click on the section marked email updates. Finally, Top Med Talk is proud to act as the broadcasting arm of EBPOM, Evidence-Based Perioperative Medicine. We'd love you to find out more about them as well. ebpom.org is their website. That's ebpom.org. And if you go to ebpom.org/meetings, you can find out about some of the wonderful meetings that we attend and cover across the year here on Top Med Talk. That's ebpom.org/meetings.